Good afternoon, folks. Today's topic A is teaching end of life care to medical students. Okay, here's the headline: Teaching end of life care. What the headline signals. The headline introduces a Q&A interview with Matthew Ellman, MD, a Yale School of Medicine professor who has spent nearly 2 decades shaping how future physicians learn to care for people who are dying rather than uh, treating end of life care as a niche specialty. The article positions it as a core clinical competency, one that requires as much international international teaching and practice as any procedure or diagnostic skill. The surrounding page content makes clear that this is not simply a academic exercise. It's a response to a long recognized gap in how medicine prepares clinicians to accompany patients through the final stages of life. The central problem described on the page. The article begins with a familiar and painful moment, a clinician telling a family, "We have done everything we can." What follows, Ellman's notes, is often silence, withdrawal, or quiet handoff to another team. Many physicians trained to fight disease with every available tool feel un, unmoored when cure is no longer possible. Some retreat behind clinical detachment, others step away entirely. The page frames this as not the page frames this not as a personal failure but compassion, but as a systematic educational defect. Medical training has historically emphasized diagnosis, intervention, and cure. It has offered it has off, offered far less guidance on how to remain present when the goal of care shift toward comfort, meaning, and rational supports. The result that patients and families may feel abandoned at the very moment they need they most need continuity and human connection. What Dr. Ellman emphasizes. Ellman argues that This pattern is neither inevitable nor acceptable. He highlights several key principles. Presence is therapeutic. Patients and families want clinicians who stay with them not only when treatments are working, but also when they are not. End of life care is a teachable discipline. Skills such, skills such as navigating uncertainty, communicating about prognosis, supporting family decision making, and offering emotional steadiness can be taught, practiced, and assessed. Palliative principles belong in every specialty, whether a physician becomes a surgeon, internist, pediatrician, or a psychiatrist. They will they will care for dying patients. Training must training must reflect that reality. Clinicians benefit too, learning how to accompany patients through dying can reduce moral distress, deepen professional meaning, and counter the sense of helplessness that often arises when cure is no longer possible. How Yale teaches it, according to the article. Ellman describes an 18-year-old longitudinal curriculum that threads end of life care through all 4 years of medical school. It is not a single course, but a scaffold experimental program with multiple components. Longitudinal patient follow up. Students identify at least one patient nearing end of life and follow them over time. Learning directly from the patient's experience. Hospice and palliative care rotations. These placements expose students to interdisciplinary teams and real world models of comfort focused care. Simulated encounters. Students practice difficult conversations, breaking bad news, discussing goals of care, responding to emotion with trained actors and facility observers. Reflective writing and discussion. Students process their experiences through essays and small group conversations, building emotional literacy and self-awareness. Facility, faculty membership. Roughly 50 volunteer faculty members guide students through cases modeling presence, humanity, and conversation skills. Assessment and feedback. The program evaluates its impact through surveys, reflective assignments, and clinical exams. That tests communication and relational competence. The curriculum's longevity and Edith reflect Yale's belief that end-of-life care is not an elective topic, but a foundational element of medical professionalism. Why it matters and the broader takeaway. The article argues that teaching end-of-life care reshapes the culture of medicine. When clinicians are trained to stay engaged rather than withdraw, dying becomes a phase of care rather than a failure of care. Patients and families experience more clarity, comfort, and connection. Clinicians experience more meaning and less moral distress. The headline then is not just about one professor's work. It signals a larger call to make end-of-life education routine, rigorous, and universal, so that every physician, regardless of specialty, can accompany patients with skill, compassion, and presence when it matters most. Here is a clear, grounded explanation of the heading: Professional Education and Palliative End-of-Life Care for Physicians, Nurses, and Social Workers, based directly on the page you're viewing. Okay, guys, here's the second part of show. What the headline signals. This section of the report examines how well the three major health professions, medicine, nursing, and social work, are prepared to care for people who are dying, and what systematic gaps still exist. The surrounding content makes one theme unmistakable. Across all professions, end-of-life education has historically been inadequate, fragmented, and underfunded. The chapter is essentially a diagnostic. It documents the deficiencies, reviews evidence, and outlines what must change for clinicians to completely and compassionately care for dying patients and their families. What the report says about physicians. The page describes a stark reality. Most U.S. physicians are not adequately trained to meet the palliative needs of dying patients. Medical schools curricula often include only a few lectures, usually folded into unrelated courses. Clinical exposure to dying patients is limited or absent. Residency programs vary widely, and many lack structured palliative care training. Textbooks, the, the backbone of medical learning, certain contain little to no practical guidance on symptom management, communication, family needs, or dying process. The report emphasizes that physicians often learn end of life care through trial and error, not formal instruction. A finding reinforced by the ASCO survey of oncologists. The report says what the report says about nurses. Nurses spend more time with dying patients than any other profession, yet nursing curricula are inconsistent and often outdated. Faculty reports only moderate accuracy of end-of-life content. Practicing nurses overwhelmingly say their training did not prepare them for pain management, communication, family support, or symptom assessments. Textbook review show that only 2% of pages address end of life topics, and most essential content is missing. The report highlights a mismatch between what nurses are expected to do and what they are taught. What the report says about social workers. Social workers play a central role in counseling, care coordination, and family support, yet most MSW programs provide minimal to no structured training in palliative or bereavement care. Students often receive only one or two lectures folded into other courses. Practitioners report feeling unprepared in nearly every skill area: communication, symptom management, ethics, decision making, and discharge planning. continuing education opportunities are scarce and difficult to access. The report notes that social work education in this area lags behind medicine and nursing, which are themselves underdeveloped. The deeper message: a system wide educational defect across these three professions. The page identifies the same structural problems. Death is largely absent from formal curricula. Clinical training rarely includes meaningful exposure to dying patients. Faculty often lack expertise in palliative care. Educational materials, especially textbooks, omit essential content. Finding Funding has come mostly from private foundations, not sustained public investment. The report argues that improving end of life care requires persistent, coordinated, interdisciplinary reform, not isolated initiatives. What the report recommends. The page outlines a roadmap for change, including facility development across all professions, better educational materials and textbook revisions, coordinated curricula spanning classroom, hospital, home and hospice settings, residency and accreditation requirements that include palliative care. Licensing exams with meaningful end of life content. Research funding to strengthen the evidence base. Leadership from professionals, organizations, and federal agencies, especially NCI. The message is clear. High quality end of life care cannot happen without high quality end of life education. Okay, guys. This is the only one I'm gonna do for now. I will see everybody Monday for shows. Until then, Gator Wellness. Take care, folks.